Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, he's going to absolutely love this episode because it's mainly just radiologists airing their pet goats. It's my co-host, Frank Gaylard.
Excellent. I'm in a very goaty mood today, Dixon.
You look it. I reckon it's been a while since we've mentioned pet goats on the podcast. It's a term that dates back to the very early episodes, a happy merging of the term pet peeves and gets my goat. What do you call them? A malapropism, I think it's called. Anyway, pet peeves, pet goats are plenty today, Gaylard.
Well, let's just start off because I have one to get off my chest in my monthly, I guess now, therapy session with you. Just yesterday, the day before yesterday, we had an in-service for a new CT scanner that our department's getting. It's all very fancy and I won't mention who the manufacturer is. And I have no complaints about these scanners. They're perfectly fine. The in-service was specifically about the fact that this new scanner comes with this new fancy laser guidance option, which allows you to mark the skin with these cross-haired lasers. And then instead of, taking a pen and a ruler to the patient and marking the skin.
Yeah.
And then
so the laser like burns a mark into them. Is that what you mean?
No, just two lines of laser that cross wherever you want the skin entry point to be.
Okay.
And then the thing that's fancy about it is that it's not just a dot, it's kind of a laser plane, two laser planes, so that outside of the bore of the scanner, you can not only go into the skin entry zone, but then by keeping the hub of the needle where the two laser planes cross, you can guide the needle in along its correct trajectory, assuming it's not bending in the soft tissues. And, great. It's good. And the rep did a really good job and presented it like it was this super science fiction, crazy, high-end, quasi-magical invention. And a lot of my colleagues are all sitting, nodding their heads, getting really excited as well. And I'm sitting there thinking, I was doing this with the old fluoro C-arm when I was a first-year registrar 20 years ago. The idea of having laser planes where you keep the needle and you push it through so that it goes to the spot that you want it to go is not that amazing.
No.
And the thing that I actually want is a robotic arm that holds the bloody needle so that I don't need to put on lead like an idiot and stand next to them, sticking my hand in the bore. Or then what we usually do is, push the needle in a bit, have a look to see where it's gone.
Yeah.
Feel annoyed that you're 15 degrees off, pull it back a bit, go back in, all the while just faffing about, sticking your hands around. And you can go online and buy a robotic CNC machine arm thing to grind away metal for a few $1,000s, and you can have it in your garage. You can have this for 10 years. But in the medical industry, presumably because of the FDA and all the other regulatory requirements, people are getting excited about lasers. And it's like, come on, catch up. I want to be able to do my biopsy while having a coffee in the console room. Let's not pretend that this is amazing. This is crude. Just bolt a bloody robotic arm to the CT scanner and let it do it. They do it for prostates, for God's sake. How hard can it be?
All right. Firstly, Gaylard, I just want to say, when I write in the episode running sheet, main segment is long, no need for any Gaylard stories in the intro, and then you do this, it's all part of the podcasting dance that we do, isn't it?
It is.
Now, secondly, we did have a robot, I reckon 10 years ago,
you?
at the Alfred that did this. So it lined it up, put the needle in, etc. In fact, I think we've still got it hanging around gathering dust somewhere. The problem was, by the time it faffed around, just like a human does, it did all its manipulations and things. It was actually quicker for you just to do the procedure yourself. And the patient was a lot happier for you to do it rather than this robot. So
yes, I suppose that's the thing.
So the technology exists. It's just, is it more efficient than you doing a couple of corrections to get in there? The benefit of the robot that we had is that it could do it over multiple slices. So instead of having to be in the plane,
Yeah.
it could do the trajectory over multiple slices and therefore get you to a target, avoiding critical structures. But it was so uncommon that we needed that it just wasn't worth the hassle. Anyway, as I said, the main segment today, Gaylord, is awesome, and it's long enough on its own without us rambling on. So we're going to be listening to the audio from a reporting mini workshop that took place at last year's Radiopedia virtual conference. It features Michael Hartung as the host, with guests Miranda Siemienowicz and Jeffrey Kanne. Michael and Jeff are both from the University of Wisconsin-Madison, abdominal and chest radiologists, respectively. And Miranda is also a chest radiologist based in Melbourne at the Northern Hospital, and she's currently the chair of the Australian and New Zealand Society of Thoracic Radiology. But this discussion applies not just to the chest, Gaylord. It's about the radiology report in general, tips for making your written reports better, and to help avoid the traps of verbose laziness.
How to craft radiology reports that don't suck is a hobby horse and is excellent pet goat territory. So I'm looking forward to this.
Awesome. Now, I'm actually going to pull a Gaylord myself here, because before we get to the main segment, just quickly, I have a new favourite thing that I need to share.
Mm-hmm.
Now, I've shared it with you, Gaylord, privately, but it's too good not to share more widely. So I have found the one thing in my life that without fail makes me happy every time I listen to it. So for context, the Radiopedia 2025 conference is coming up in July, and all our lectures have English subtitles. They get checked and corrected. So there's a process. It involves Vimeo AI doing an initial speech recognition. Then ChatGPT does some context-based, corrections to the transcript. And then finally, a human gets to have a look at it. Anyway, the other day, I'm looking at something flagged in one of your lectures, Gaylord. And I was like, how did that word get so wrong? Like, I could easily tell from the context what the word should be, but the AI was just way off. So I took a little listen, and this is what I heard. I'm going to play it for everybody now. Here it is.
Because hypoxic ischemic encephalopathy is usually ischemic.
Hypoxic ischemic encephalopathy.
That's just my brain hitting a pothole. It's my answer to the infamous Trump Covfefe tweet.
I actually think it's the fact that you continue along, just plowed right on.
I'm not even sure I noticed. This is the thing that worries me. I wonder whether that's how I say encephalopathy all the time.
Because hypoxic ischemic encephalopathy is usually ischemic.
It's just so good. Without fail. The other day I was walking to school to pick up my daughter, and without even playing the audio, just thinking about it was enough to cheer me up. Anyway, it's the best. Your little audio gift to the world, Gaylord. Anyway, we better jump into the main segment now. So Michael Hartung, Miranda Siemienowicz, and Jeffrey Kanne. I say their names because I trimmed the part where Michael introduces them in this segment for brevity. So this should work well as audio, but just so you're all aware, there are a series of little exercises in here, like which of these report findings, statement A or statement B, is better and why. However, I made sure that Michael read each option aloud, even though they were on the screen for this very reason, actually, Gaylord. I preempted this. I may also try to place the text from the exercises in the podcast description in case anyone wants to read along there. All right, I might hand over to Michael now. Everyone listen out for those pet goats in here. And then Frank and I will be back for another chat in the encephalopathy. Sorry, I mean outro.
My name is Michael, and I'm joined here by two thoracic radiologists, both of whom have a passion for the major product that radiologists produce, and that is our written reports. How about we kick it off with this icebreaker question? What has gotten you interested in the topic of radiology reporting? And Miranda, we can start with you.
Sure. I have a deep interest in language. I'm bilingual, so I'm fascinated by literal and non-literal translation between languages. I took a grammar subject at university during my medical degree, and also took a large number of courses in fiction and non-fiction writing and editing. So It's not so much what sparked my interest in reporting in radiology, but the kind of mindset that I came into radiology with.
Awesome. What about you, Jeff?
Well, I've always had interest in language, and particularly the English language and how it evolved over time. And when I got into medicine, I recognized that medicine has its own version of English with some very awkward constructions and even incorrectly used terms. And I see a lot of that creeping into radiology reporting.
Yeah, for sure. Yeah, for me, it kind of occurred as I began to follow cases up during my training. And I started to realize there was a good deal more confusion and unspoken frustrations about the contents of our report. And that got me thinking and considering ways that we might improve them. And so for my first few years of practice, I often cringingly would review my old reports and tried to consider ways to simplify and clarify my language to avoid any confusion and kind of give the best chance at advancing patient care. And so that is a good segue into our next question. Let's consider current issues that we're facing today. Of course, there is that excellent paper from Dr. Enfield from about 100 years ago that talks about, and I'll quote, the report which describes in detail all that the röntgenologist sees in the film or on the screen, but does not tell what he thinks about it, what conclusions he draws from it, or what it means to him. And that sounds like a nice summary of one of the major current issues from today as well. Miranda, I'd love to hear your thoughts on this question, which is, what would you pick as the top one or two major issues with radiology reporting today?
Just start by saying that that's an amazing paper. It's published in 1923. It's 100 years old, and it manages to touch on everything that we teach in radiology reporting today. It touches on clinical implications of radiology reports and don't treat the X-ray, treat the patient. It touches on weight of probability, expressions of uncertainty, everything that is key in what we are still talking about today is already back there. It's bogged down in some troubling androcentric language and very much within the context of the day. There's this beautiful comment in that paper where he laments that surgeons are often too impatient to let their pupils dilate sufficiently to look at the imaging. So it's absolutely gorgeous, and I really love how it pulls out all of the threads that we're still dealing with in reporting and all of the challenges that we put on ourselves to produce excellent reports. But to your question, I think one of the really central modern issues and challenges in reporting is the different uses of technology that we have now to assist radiology report production. And I'm thinking about these software packages that come out that auto-populate reports, particularly in ultrasound, where you have a sonographer who's filling in their worksheet electronically, and that gets put out into a sort of guesstimate report that the radiologist can basically just sign off on. So measurements are dropped into to and comments are added to partial sentences, and it all comes out like a report that is then offered to you to approve or otherwise. The quality assurance around these kind of technological aids is really, really critical, because so much of this software produces reports that have really senseless repetition, convoluted sentences, poor grammar, and a really sloppy final outcome. And it's really on the radiologist to own the quality assurance of that final report. This is our interface as a profession. This is our sort of public face, and being really mindful of how that looks and how readable it is and how clear it is and how clearly it communicates what's wrong with the patient is absolutely critical. So in Australia, the Radiology College put out a guideline on structured reporting, which is a document that aims to equip practices to evaluate different structured reporting tools and technologies for fitness for practice. And my contribution towards that guideline was really around this concept of quality assurance and clarity and excellence in written language, and also caution in overfitting some of these automatic templates to complex clinical scenarios. So this kind of transition to a structured reporting framework while retaining a sense of quality assurance, I think, is really key.
I think that's a great point. And I think structured reporting, when it's sort of put out there without thinking, is it mimicking a search pattern or kind of a coherent way of reviewing the study, or delivering the information in a way that is accessible and helpful for the ordering providers? I don't know if I would be as unkind as saying the majority, but many structured reporting templates out there, I think, can be a little rough to read through and need an updating and a refreshing. It might interest you to know that while we use structured templates for our abdominal pelvic imaging, we leave the fields blank. So we don't have pre-filled normals. And we do that for a variety of reasons, one of which is that our patient population is really quite complex, and often having blank fields isn't helpful at all, but also from a training standpoint to help the trainees and reinforce, that language of radiology. So we found that to be a good balance. You still fulfill those checklist items, but you're not staring at and being biased by default normal language for a potentially very abnormal patient. So that's where we've landed and found that to be a good balance over the last few years. Jeff, what about you? What would you say are the top one or two major issues with radiology reporting today?
I still see a lot of reports that are so verbose, or the discussion is very vague. I can't figure out what's going on. And if I'm spending more time trying to figure out what the report said as a radiologist, I know the person who ordered it is probably even more confused. And the other thing you'll sometimes see are meaningless impressions where they just repeat the findings, or I've even seen them repeat the history. For example, I've seen indication interstitial lung disease. There's some vague description of findings. I mean, clearly that radiologist wasn't comfortable with the exam, and the impression says interstitial lung disease. So we've gone full circle, didn't get anywhere. So that's the other thing you'll see with impressions is they are too long sometimes. I try to limit mine really to one point. Occasionally I have to bring a couple more, but I try to keep it as one sentence or one single discussion, because sometimes I'll see a very important finding, number 7 in a list of 10, like 1, 2, and 3 are just irrelevant. And so again, with everyone being so busy, varying levels of experience on the clinician side, we have a lot of mid-level providers who have very focused clinical experience. They may miss the most important thing because they don't understand there's too much in the way.
Jeffrey, I think you raise a really good point that the clarity to the reading referrer who's actually got that report in their hands is the be all and end all. There was this excellent paper that was published in 2001 by Chapman that took a large number of chest X-ray reports, and it showed them to 7 reading referrers, respiratory physicians, and they all read the same group of chest X-ray reports, and they all just chose between 2 binary options of whether the chest X-ray report said there is pneumonia or there is not pneumonia. 7 readers, yes, no for pneumonia across this bunch of chest X-ray reports, and they found disagreement between the audience members, these readers, of between 6 and 28% for any one report for this simple question of is there pneumonia or not. And when they broke this down, they found a number of factors that were contributing to this, but these are all to do with readability and the cleanness of the report. And I'm sure we're going to touch on a lot of these things in the discussion today, but it's really important that we all keep very front of mind as radiologists that our confusion that we introduce into our language has a profound impact on the recipient of the report and their ability to take the next step with the patient.
Yeah, no, I couldn't agree more. And I think even that point highlights that the threshold or the floor for helping is really quite low, right? So we just simply need to state a diagnosis clearly and as clearly as possible, and we can be helpful. And I think so many times with our reporting is we crowd it with incidental findings that may or may not be important, or incidental observations, and then our reader gets bogged down, and then that main simple message gets lost. Yeah, I try to sympathize with the ordering providers, anticipate that they're really busy, they're quickly reading our reports, they're trying to figure out what to order, what to do next, and they don't want any additional information that's not actionable or not helpful. From my end, to answer the question, I think the biggest issue, and I know, Jeff, you just touched on this, is repeating the findings in the impression without a synthesis or consideration for the next steps in management. And this really gets at the hardest part of radiology, and that was also touched on in that paper by Dr. Enfield. It is the step in our reporting that takes the most effort and expertise. So it's really not surprising that it gets neglected, as it's honestly the hardest part of making a good radiology report. My perspective is that we can acknowledge this tendency and intentionally force ourselves to put extra effort in to make sure that our own reports are going as far and being as helpful as possible to advance patient care. All right, well, I think it's time for us to have a little fun and discuss a few popular but potentially polarizing phrases or hot topics in radiology. So we can start with this one, and that is the phrase cannot exclude. And so the example here, I picked a chest one for you two, and it is enlarged mediastinal lymph nodes. While these may be reactive, malignancy cannot be excluded. So what do you guys think? Should radiologists use this phrase in this context?
I'm struggling to remain calm in my seat as you read this out, as I'm dying. We need to expunge this from the vocabulary completely. What we really need to be presenting is a weighted probability of differentials. What this language is saying, that there's a reactive differential and there's a malignant differential. And when you throw away this phrase of cannot be excluded, you are giving the referrer absolutely no information as to how likely cancer is. It can't be excluded, but it's 1% likely, and almost certainly there's a reactive lymph nodes, so do a CT in 3 months just to make yourself feel better. Or you're saying that these could be reactive lymph nodes, but you know what, cancer is 50 or 51% likely, so you better start thinking about doing a PET and getting an EBUS. And there's a really big difference between those two scenarios, which has absolutely not come across in this language whatsoever. Remove it, delete it, and work on that weighted differential of less likely, more likely, and point it towards the next step that would be reasonable based on your judgment of those two options.
Yeah, again, we should exclude. The other thing is it conveys a lot of lack of confidence. That's one thing that you can see in some reports. And sometimes we just don't know things, right? We can't tell. We don't have enough data. The findings, there's enough overlap. But like Miranda said, we really need to, weigh in on something. So if I think nodes are reactive, I say presumably reactive. If it's sarcoid, I just say it's sarcoid. If I'm really concerned about malignancy, these are, very well may be malignant. And then give the appropriate recommendation, which is usually referral to an expert. But as soon as you start seeing comments like that in reports, especially if you see them over and over again, and I see this in a lot of PET CT reports, it says, but can't exclude malignancy. And it's like 5 times in the report. I lose all faith in that report.
Yeah, I completely agree. And I think, there's certain phrases that if we find ourselves reaching for them, it's almost like a forcing function that more effort and thought is needed. So if we say something cannot be excluded, what that really means is think about where you fall in the probability. This is basically paraphrasing what you just said, Miranda, but kind of decide where you fall in terms of levels of concern and probability, and then recommend the appropriate next step for action. But don't just leave it at that. That's stopping short of our responsibility and really kind of just throwing out an unhelpful phrase and moving on. So, I have another one here, and this next phrase is closely related to the previous one, in that both have a vague, deflecting quality, and that's often unhelpful, as we've already touched on. So this next phrase is clinical correlation is recommended. And we'll continue with the mediastinal lymph node example, where we'll say enlarged mediastinal lymph nodes are indeterminate, recommend clinical correlation. So what do you think, Jeff? Is that a helpful thing to add, or do you have any rules for when you might use this phrase?
Never. It's a no-no. If I see it in a resident report, it gets deleted immediately, because that's their job, right? I mean, they ordered a test to get information, and they're going to take the results and correlate that with their clinical evaluation of the patient. It's like telling a surgeon to operate or telling a pulmonologist to do a bronchoscopy. And my parallel is, I say, well, sometimes we get orders that say evaluate lungs. Okay, well, I was going to ignore the lungs on this case and just look at everything else. It's like, well, that's kind of like my job. So it's meaningless. And in today's world of the electronic health record, we can do a lot of that correlation ourselves. We can look up lab results. We can look up biopsies. I even look at pulmonary function testing first to see if it was done, echocardiography, all these things. And I think that's what makes you a better radiologist. You may be limited to how much access you have depending on your practice, but most of us have a fair amount of data at our hands. So for example, let's say these mediastinal lymph nodes. Well, if I see the patient has hypercalcemia, they have a dry cough, and maybe some skin lesions, well, I'm just going to call sarcoid, or come down pretty hard on it and send them to a pulmonary physician. If I see they've got weight loss, they've got night sweats, and they got a leukocytosis, I'm thinking lymphoma or some other lymphoproliferative disorder, right? So I can do that and put that in my report. And then that conveys to the ordering provider that I did my job. I'm not a technician who just describes things. I'm a doctor. I think about it. I make medical decisions based on the data available.
I completely agree. Miranda, what do you think? Clinical correlation? Can it be recommended?
I completely agree with Jeffrey. I mean, what's this even saying? Is it telling the clinician to look in the patient's mouth, to look behind their ears, to hold them up against a brightly lit window? There's absolutely no directive here. And if there is something to say, if there is something valuable that you're saying, oh, the next step in here should be, I don't have the information from the clinical history or the electronic medical record, I can't differentiate between those two. But the next thing that would do that would be an EBUS. It would be another investigation. Then that's what you're writing. You need to finish the thought. You need to actually give some kind of next step.
Personally for me, if I'm wanting to recommend clinical correlation, I have to be specific. I have to say which specific lab, or I think importantly, if it's an imaging study, what feature, what series, what sequence am I looking at that is going to actually make a difference in determining what the significance of that finding is. And if I'm struggling to come up with it, I know that the next reader is going to also struggle. So a lot of times in our practice, that leads to biopsy. When something's indeterminate, more imaging is often unlikely to be revealing. And a lot of times we're recommending sampling. So then I would recommend the route of sampling and the target for sampling as well. So I really kind of force myself to say, where is the endpoint in the workup for this patient, and to direct the care appropriately.
I had a mentor in my training who used to tell me to say what you think. That's what we're all saying here. It's not just tell them to think, it's say what you think. I think the next step is, I think this is likely to be. I think that that's possible but unlikely, and do this specific thing. To say what you think. I agree.
Okay, so this next one is a potentially polarizing topic, and that is, should we use the phrase normal? And Jeff, you already said you like the phrase normal. I personally like the phrase normal, but let's talk a little bit more about normal. And here we have some examples just for clarity. So for example A, it would just be simply stating the lungs are normal. Example B has a descriptive phrase which says the lungs are well aerated without evidence of nodules, masses, consolidation, or other parenchymal pathology. And then C, I have some variations of the phrase normal, including within normal limits, no significant findings, unremarkable, and also no definite abnormality. So Miranda, I'd love to hear what you think, where you fall on this.
Yeah, I love the word normal. I think it's a very significant touchstone for the clinician. When we use that, there's just no ambiguity to it. They know that the test showed nothing that they need to act on. And that's key. That's absolutely key. So I use it liberally whenever it's appropriate. This same mentor of mine, in his reporting of fracture x-rays, used to use the sentence, no fracture detected or no fracture seen. And what he was trying to get across with that is that you can't exclude an occult fracture, but there isn't a displaced one. There isn't something that's come up at this angle, with this projection, with this degree of penetration, so no fracture is detected. But I disagree with that, because in my view, the word normal is written in the setting of a radiology report, so it already implies that the test within the test's capacity is normal. I'm not saying that the patient is normal. I'm saying that this X-ray, which has been performed to adequate penetration and has been ideally positioned, is normal. And a discussion of the limitations of that, I don't believe, fit in the context of an adequately performed study. So sorry, Bob, but no fracture, full stop.
Yeah, no, I do agree that we should be comfortable that everybody accepts the inherent limitations of an adequately performed study. So yes, it's not a CT, it's not a bone scan, but I don't see an abnormality or something to that effect, or not an MRI, which might have greater sensitivity. But we can be comfortable kind of within that modality and with any limitations in the modality of calling it normal. And certainly if we felt like it was an inherently limited study or an inadequate study or the incorrect study for some reason, then we could have the responsibility of recommending an appropriate follow-up. Jeff, what about you? I know you said you use normal.
Oh yeah, that's my default. My radiograph report is just normal chest. That's all I say. I don't talk about anything else. And I've never once had a complaint for using the word normal. So that's my feel. If you look at, like, for example, B with all those things, I would say, well, they left out airways disease, they left out vascular disease. If you look at C, what are the normal limits? I don't know what the normal is. The lymph node too small? Is it too big? I mean, there's more to it than that. No significant findings implies, well, there are findings. What are they? And at least in the US, patients get their reports as soon as I sign it. And so they read them. If you say there's no significant findings, some of our patients are pretty detail oriented, even to the point of, on the obsessive side, that if there's anything funny in it, so they're like, well, what is in there? If you said there's no significant findings, unremarkable, I don't know what that means. And then no definite abnormality gets back to my earlier comment about lack of confidence. Well, is there an abnormality? Well, there's no definite one. Well, that doesn't mean anything. If you say there's no definite metastases, well, unless you have pathology or clear destructive process, you can't prove it's a metastasis, but we use our medical judgment to say something is almost certainly a metastasis. So I like normal. It leaves no questions unasked. And so, like, a normal chest CT, for me, the impression says normal.
I think I'll say that I use the word no definite when I am using it in part of a sentence that describes a significant limitation. So there's substantial motion artifact with no lung nodule within this limitation, or whatever it is. So I will use language that says no definite or no gross if it's in the same breath as a description of some kind of inadequacy of the study.
Mm-hmm.
The next point from that is that if you're going to make a technical limitation reference, you need to give the clinician the information that tells them whether or not they need to repeat the test and do something else. So if I am going to use something like no definite, I'm using it only in the context of there is a technical inadequacy of this study. Your primary question has been answered or has not been answered, and you either need another test or not.
I'd argue you could even drop that. You could just say, no acute abnormality within the limitations of the exam that you've previously stated those limitations. You don't even need to add the modifier definite. It's sort of an unnecessary word.
That's fair.
Yeah.
That's fair.
You're saying I have done to the best of my ability. I've acknowledged the limitation. Like, for example, PE study in the patient's breathing. I'll say I can clear to X level. Everything else looks okay. The lungs are all blurry, but there's clearly nothing big going on. So I'll just say no acute abnormality within the limitations of the exam.
I think that's really well put. Yeah,
I agree with that.
And if it's truly a non-diagnostic study, I'll say it's non-diagnostic for pulmonary embolism, no other abnormality. Yeah. And you try to figure out why. You don't just say it's non-diagnostic. The patient can't hold their breath? Is it a size issue? Is it a contrast issue? And then we could recommend an MR, a VQ scan if we think that's going to answer the question better. If we know repeating the study isn't going to help, that's usually a private conversation to the clinician you call down or message down there, say, look, it's a bad study, but repeating it isn't going to be worthwhile because of this, and maybe we can try later.
Yeah, no, I think those are great points. I think the qualified versions of normal have a role, and that is when there's an inherent limitation that needs to be discussed and potentially remedied with a recommendation. But to take those qualified versions of normal and bring them into the true normal, it's a bit of a shame because I know, Jeff, you touched on it, and I feel the same way. Patients are increasingly anxious, and we have an often anxious patient population that we care for. And it can be almost seem like a little mean to have a normal study, but not really deliver it as fully normal. No definite CT evidence of metastases. And I think of this poor cancer patient, everything they've been through with the normal study, and yet they feel like the best they're walking away with is no definite evidence within the modality limitations. It's a little rough, For trainees, I guess I'll just comment that, especially early on in their training, I prefer that they at least get comfortable using those longer descriptions so that they're mentally engaged and going through at least some sort of verbal checklist that we're kind of pooling on with all of our experience over time. So when I look at something and call it normal, I think mentally I've gone through a whole process of going through different aspects of an organ or the bowel or something. But I don't know that the residents necessarily have formed that yet. So I think if they just say normal, I kind of wonder what's firing. So it's nice for them to have to be practicing that language, I think.
I agree with that. It's part of internalizing the checklist process as a junior.
Yeah. Well, we've touched on working with trainees a bit, and so let's discuss that some more now. Working at an academic institution, I have had to learn to carefully consider the advice that I give trainees and also how that advice might change over time. And I think reporting goes through a sort of maturation and pruning process throughout the years of experience. Jeff, what are the major challenges and frustrations that you are facing when working with trainees on reporting?
Well, one of the things that frustrates me is, so I created these templates to help guide them through cases, but then they go and change them, mess them up. Sometimes it adds a lot of meaningless bloat, or they, I'll have a phrase, normal, and they'll say no definite evidence of. Sometimes they'll observe a finding that isn't there because someone else said it on a previous report. I'm like, I want you to look at the study we're looking at and describe what you see now, not what you think someone saw 6 months ago. And it's hard for them to call normal, but as they get more experienced, and especially the senior residents who spend a lot of time with us on chest, I push them to call things normal when they're normal. They'll ask me, and I always turn around with a question for them, and then I get them to get to normal, and then I'll start seeing it come through.
Yeah, that's a great point. Miranda, what about you? What are the major challenges and frustrations that you're facing when working with trainees on reporting?
I think that the biggest challenge of working with trainees is that the primary resource for learning how to report a radiology study is the bank of radiology reports that comes out of the department where you're learning. So these trainees come through and they're reading everybody else's reports, and that's how they're internalizing language and descriptors and structures and sort of degree of relevant detail, and they're reading the good reports and they're reading the reports that don't meet these principles. And that's where they're absorbing it all from. So really the adequacy of teaching and how to deliver that is the biggest challenge. In Australia, we have an online e-module that trainees are required to complete as part of their training, and I supported the development of that and contributed to this module. And it goes through a lot of the things that we've been talking about today. And it goes into quite a lot of detail about clarity and expression of uncertainty and dealing with language and the way language is received by different parties and making sure that the message is communicated clearly. But that's a 45-minute process that they sit down and work through. And if that's the thing that they do in their first year of training and never think about it again, it really doesn't carry through and it really doesn't continue to teach the principles. So it's this side-by-side reporting where you can edit what they've put through with them next to you and teach and explain the reasons that changes are being made that really make a difference. And I think if that is continued throughout the training, then this is a really teachable skill. And the literature shows that too, that the clarity of communication of trainee reports as compared to the same report edited by a consultant really increases when you look at how each of those versions is read by the referrer.
Well, and I do want to congratulate you on creating the curriculum. I mean, we don't have anything like that I'm aware of in the practice in the US. And I think it's an amazing model for people to follow throughout the world to really put reporting first and kind of formalize the education surrounding reporting and catching residents early, getting them thinking this isn't just some sort of passive, process that you kind of pick up, but this is something that has a lot of literature and science and data behind it. So well done, at least starting or trying.
Thank you.
Yeah, from my end for issues with trainees, I think what I've been noticing recently has been that a lot of trainees seem to be approaching staff outs like a negotiation almost, where they're getting my opinion and adding whatever bits that I said sound good to them for the final report, but then kind of editing it and changing it as they see fit. And from my end, I'm somewhat flexible about the findings, but I'm not really flexible in most cases for the impression. And I have to frequently remind trainees to take detailed notes so that the impression is a near verbatim product of our discussion. I will say I've experienced staff outs like in this example report, which I'll read out loud, where I'll add layers of nuance. And instead from the trainee, I will receive a very simple paraphrase. So here I have an example. And so what I wanted in the impression was small bowel obstruction with abrupt transition point in the distal ileum with sharp angulation at the transition point, indicating that this is most likely caused by adhesive disease. And instead what I got was high-grade small bowel obstruction. So, and while that might seem fine, and maybe even the second one's preferable to some people, the reason why I have a longer description, especially cases like that, is I want to avoid forcing the ordering provider to read my findings to get a 90+% picture of what's going on. I want to provide a picture that's enough for most readers. And of course, they can dig into the findings if they want to. For you, Miranda, are you noticing similar issues with paraphrasing or just in general, any tips that you might have for successful staff outs?
Yeah, I just want to start by saying that the word staff out is a North American term that we don't use in Australia, and I love it. So thank you. The descriptive grammarian in me takes that and thinks, what does that mean? That to me, it sounds like stakeout. There's something sort of aggressive in it there. Anyway, so thank you for that mental image. But to answer the question, there's always that challenge in making sure that the delivery of what you're trying to educate about lands and is absorbed and comes back out in the next step for the trainee. And for me, the way I do that is by having them sitting next to me as we go through the report. And if I'm teaching something about degree of description and clarity of writing, then I'm doing it at the keyboard, my hands on the keys, me typing and explaining what I'm doing while I do it. Sometimes I apologize first.
So you'll edit the trainees' reports on the spot, is that
yeah,
what
and it's a beautiful way of teaching, I think, because you can take the sentence, you can highlight the first half and you say, you ready? Watch this, delete. It still says the same thing, doesn't it?
Right.
And when you're doing that live and when you're doing it with them, they're really seeing the way that the alterations to the language is getting the meaning across. We do that in a workshop setting as well, where I get the trainees together and I've got a Word file on a USB key that has a whole lot of unedited registrar reports, and I put them up on the screen and we go around the room and talk about what we can do differently and how to change things, how to trim them down, different little quibbles that we can polish up and improve the quality of the output.
Mm-hmm. I think that's wonderful to share your complete thought process and even the editing process. Because I know even for me, and this is probably a big part of my first couple of years of practice and has slimmed down a little bit, but I would heavily edit my impression statements because I just wasn't very happy with them. And I learned a lot in the process by kind of going through that iterative process and forcing myself, that first go, the first time you dictate something, it often needs a little refinement after that. So showing them how that process of refinement goes. And I've also similarly highlighted a significant portion of it, delete, and then look, it still says the same thing. Isn't that one amazing? Yeah. What about you, Jeff? Have you found, when you're trying to deliver nuance and you're maybe sensing that the trainee is not picking up or may not put that nuance in the final impression, how do you handle that situation?
So I usually, what I do is I usually review the case myself and I look at their report and I edit it as I go. But then I clearly can sense they didn't get the nuance of the case. So what I'll do is I'll have them come over and put the report aside and say, well, tell me what's really going on here, and get them to tell me what they think is going on, which is usually what I wanted them to say. I'm like, okay, well, that should have been your impression.
Mm-hmm.
And they learn. And luckily we have the technology. They can compare my final version with their preliminary version.
Mm-hmm.
And it like color codes the things. I think I have the highest index in the department for number of changes. I think it gives like percentage. I think
we tracked that. That's interesting.
The whole report would be different, but anything from a little comma that's supposed to be there to rewriting the entire impression. So that's what I ask them. I make them verbalize it to me, because for some people it's hard to write it. Even though they're dictating, it's not the same as having a conversation with another person. Also, it gives me a sense, do they really understand the case? And if they don't, like Michael's example with the bowel obstruction, they don't know what's important and why. So we can say, okay, well, what would the surgeon want to know and why? So again, teach them to be doctors and not technicians.
Yeah, I think that's a great point. And also, I think, when we are trying to deliver an impression verbally, we tend to state it really clearly in plain language, almost, every day, or kind of common physician language. But when we write something out, especially I think trainees are really eager to do this, is they'll dress it up with a lot of bloated language that makes it sound like it's, got a lot more sophistication than it really does. But we're often just delivering simple ideas, even going back to the earlier comment about pneumonia or no pneumonia. I mean, that's often what we're simply trying to communicate. And you could say, patient has pneumonia, there's no pneumonia. But the impression statements, for whatever reason, say much more vague, strung out sentences where that main idea gets lost. So having it reflect that spoken language, I think, is really helpful. I usually try to avoid using a speaking opportunity as a platform for targeting pet peeves. I think we can make an exception just for today. And how about we start with you, Jeff? Do you have any pet peeves that you'd like to share?
Yeah, I can't stand awkward constructions. Like residents will use some phraseology that they would never use in any other format. There has been resolution of the previously seen 5 millimeter right lower lobe lung nodule that was present on this date that is now gone. I mean, right. You could say the right lower lobe nodule has resolved.
Right.
They use a lot of passive forms. They use a lot of redundancies. And it's hard to figure out what's going on. I mean, you read it and you have to read it 2 or 3 times to understand what they mean. The other thing I don't like is, and I mentioned this earlier, there's too much bloat sometimes. Sometimes the impression's longer than the description, and there's 10 different incidental findings, 9 of which don't require any further evaluation. And oh, by the way, there's a 20 millimeter lung cancer hiding in there. And then finally, just grammar and dictionary errors. They use words that they don't know the definition of. It sounds good, or it's often they hear another radiologist use it, or just basic things. The verb and the subject don't agree, and having a background in English, that just, it rubs me the wrong way.
Completely. Miranda, what about you? What are the pet peeves that you'd like to share?
Yeah, I agree with all your points, Jeffrey. It's a beautiful example of the bad alternative to resolved lung nodule. My pet peeve is shying away from the challenge of producing the best possible written radiology report by holding on to your personal style. It's a phrase that really makes me cringe, because if we are wedded to the sound of our own voice, then it prevents us from stepping back and critically appraising the final output, which is this good quality report. Written radiology report is not a format, it's not a forum for expressing some kind of personal style. There's a lot of creative outlets that we can pursue for doing that. But if we're talking about scientific reporting, what I tell my trainees is don't think about this as a piece of writing. Think about it as a newspaper article. We've got a short turnaround time. We've got to have a strong adherence to facts. We've got to get a clean message across. We're reporting 100 studies a day. The referrer is reading 100 reports a day, and they need to know what's going on. This is not about your favorite way to say things. This is about how are you going to get your message across correctly and accurately. The mantra I always give them is shorter is better as long as it's accurate. We want to get it right down as long as we've got the key information in there.
Mm-hmm.
That's why normal is good.
It's very well said. I love the newspaper.
Absolutely.
I love the newspaper deadline analogy. That's wonderful. From my end, for pet peeves, I think, and I know we've kind of already touched on this, but I do think we tend to use overly complicated language for communicating simple ideas. And so there's some words I think we could stop using altogether. One of those is interval, where if anytime you find it in a sentence, you can just delete it and it doesn't change the meaning. It's kind of amazing, but it finds its way into many of our reports. I think it's completely understandable, as I mentioned before, to want to sound sophisticated. And I think for our trainees, that's a particular desire as they want to establish themselves in our specialty. We can, to some extent, flex those muscles in the findings section where we have to deliver that technical assessment of what is in the imaging study, but that's not at all appropriate for the impression. So the impression is clear and short, as you mentioned, while being accurate and written for others. So in light of these comments, I have an example findings section and an impression that we can take a look at and see what might be improved. So first we'll tackle the findings. And let's consider how someone might report lung nodules on a follow-up examination. So example A is redemonstration of lung nodules that show interval increase in size compared to the previous examination, the largest measuring 1.5 centimeters versus 1.0 centimeters on the prior study. And then B, the rephrasing of that is growth of lung nodules, the largest is 1.5 centimeters versus 1.0 centimeters. So Miranda, how do you react to those examples, and what are the underlying issues that you see that might lead to that great discrepancy that we commonly see in our reports?
So we're really all aiming towards getting as close to answer B as possible with everything that we put out there. Shorter is better as long as it's accurate. And the tool that we have to work through this in practice is, there exist a number of these out there, but readability indexes of written language. And one of the most commonly used ones in English is the so-called Gunning Fog Index. This was developed by a person called Robert Gunning, who produced this in 1952, and it's a quantification method for looking at a bit of written English text and calculating out a figure that is supposed to roughly correspond with the number of years of formal education that somebody would need to be able to understand that piece of text. This is a complicated formula that uses quantification of the number of words in the text, the number of complex words as a subset of words, and the number of sentences. And then there's some numerical manipulations that go into the formula as well. But it spits out a figure that allows you to analyze this. And when you think about the way that formula works and the different parameters that go into it, when you look at the number of words that we have, shorter is better as long as it's accurate, less words is better. We're sometimes constrained, obviously, by the number of findings that we need to communicate, but it's a matter of being mindful of what needs to be communicated and what doesn't, verbosity and simplicity of description, but then also simple things that we can do every day, using the phrase gallbladder neck calculus instead of calculus in the neck of the gallbladder. It's just a shorter version of exactly the same thing. And on a micro level, just one of those examples. Complex words, obviously we can't get away without using some specific complex language because we're talking about specific terminology. But then on a micro level, on a day-to-day example, the word within can always be substituted with the word in. And it's the same thing, but it's shorter and it's easier. And then in terms of number of sentences, which is the other parameter in this readability index, it's about making sure that you haven't been going on and on and on when you could have put one or two full stops halfway through your thought to make this easier to absorb. And certainly when I'm editing my own reports, dropping in a couple of extra full stops before I sign it out is a really common practice in my own self-editing. When you run that first example through, that option A, through the Gunning Fog Index, you get a figure of 18.2. So supposedly, this is a college graduate who's had 18 years of formal education, who will be able to pick apart that sentence and will be completely okay. But option B has a Gunning Fog Index of 4.8. That's a primary school student. And if you think about how tired you were as an intern out on the wards, doing your 14-hour days and doing your 12-day fortnights, you kind of felt a little bit like a primary school kid at the end of your last shift when you were trying to pull out the last radiology report and get to the next step for your patient. So there's really clear sort of quantifiable approaches that we can use when we're thinking through this on a deep level.
That's wonderful and well said, and certainly a lot safer to deliver the information at that education level than the former. So for our next example, this impression slide hits at a lot of concepts, and I'll read it first, and it is admittedly a little long, so please bear with me. So this is a liver MRI impression, and impression A states, there is an indeterminate T2 intermediate, mildly heterogeneously enhancing, diffusion restricting mass in segment 7, measuring 3 centimeters. Both benign and malignant etiologies can be considered. And example B, 3 centimeter mass in hepatic segment 7 has imaging features concerning for either primary liver tumor or metastasis from an unknown primary. A benign lesion is also possible, but felt less likely. Recommend ultrasound guided biopsy for tissue diagnosis. So, my quick assessment, when I look at this, is that it violates several of my own reporting rules, such as unhelpfully using technical language that nobody outside of radiology understands, followed by a non-committal, non-action oriented differential. The second impression uses more universally understandable language and focuses on the most dangerous diagnosis that should direct management, and that's the possibility of cancer, followed by a recommendation to resolve the uncertainty with a specific type of biopsy. So I think, I know the shorter is better mantra, and I guess the second impression is a little longer. It's a little more nuanced, but it also, I find it more readable and directive. So I personally find myself definitely working towards that goal of shorter is better as long as it's accurate. But I think for tough cases, I tend to kind of migrate towards a almost like a consult note feel where I'm making a complete assessment of the situation, addressing the uncertainty and the possible diagnoses, prioritizing by the most risky diagnosis for the patient, and then directing the management appropriately from there. So yeah, with all that said, what do you think, Miranda? Is it okay to let loose and have a full paragraph for the impression when an occasion calls for it, like in this example?
Oh, I agree. And I think the as long as it's accurate part of the mantra is covering just this, that the first example, option A, doesn't give you that weighted probability. And that's where the phrase less likely is doing this work. You've got this, you've got that, which is less likely, and this is how you're going to sort it out. The clinician needs that to be able to take the next step.
Yeah, I agree. And Jeff, what about you? I know a goal of yours is often to have brevity and clarity, but do you find sometimes that cases are complex enough that you may have to kind of really get into a discussion like this, or?
Oh, absolutely. Sometimes you have a very complex lung cancer case, or you have multiple lung cancers, and your job is to convey which is the one that's the most concerning, but not miss the fact that there are other ones that also need attention. So yeah, I tend to make it a very succinct discussion, but sometimes my impression is not just sarcoidosis, but rather 2 or 3 sentences discussing the complexities of case. Or sometimes you have 2 different things going on, and you think you need to make that distinction. So yeah, I try to avoid technical terms. One thing we didn't touch on, but sort of related, is even in the body of the report, I encourage people to get away from the technical terms. Instead, Miranda had mentioned gallbladder neck calculus. I would just say non-obstructing gallstone or obstructing gallstone. Because again, patients are reading these reports, at least in our practice, and instead of saying the osseous structures, say bones.
Mm-hmm.
Everyone understands bones. I always say to the residents, you don't say pulmonary structures, you don't say the renal structures. Why are you saying osseous structures? But use terms that people understand, because you want the person with the appropriate training, but maybe the least amount of experience to be able to understand. So that first-year medical student or exhausted intern at 2 a.m. can look at your report and have a good idea what's going on, and not have to go back to the rudimentary Greek and Latin we learn in med school. It's just part of language, and things can easily get confused. You have cholelithiasis, choledocholithiasis. You can imagine it could easily be mistaken. But if you said, obstructing stone in the common bile duct, done.
Mm-hmm.
Yeah, great points, Jeffrey. I think lung fields fits in that list with me.
There's no fields in the lungs.
I used to get told fields are for cows. This is just the lungs.
I have a cartoon of lung fields in my reading room. It shows little lungs growing on a stalk.
Oh, beautiful.
I love it. Yeah. For one of the observations that I have when I look at the liver MRI impression example too, is that I think about a family member calling me up with that report and saying, this is what my impression said. What should I have done next? Reading something like that, I say, well, you need to have that biopsied. I'm concerned, or if I felt like there was some other imaging study that might be appropriate. And so another stop for me, I think, is when an impression is getting long and potentially unhelpful. I try to say, well, what would I want for myself or a family member if they called me or had this same imaging study? What would be the next step for them? And that helps to push me and challenge me a little bit to stretch and say, okay, well, what's the next action step? And keeping the impression focused on that. All right, well, we are on the home stretch now, and we can consider our last question. And our last question is this: do you have any tips or suggestions for how to improve your reporting? So we'll start with you, Jeff. I'd love to hear your thoughts on this question.
Yeah, I think when you're finishing up your report, you should ask yourself, did I convey what's important? And that includes not clouding it with unimportant bloat. Did I answer the question or questions that the study was done to answer? Sometimes you'll see that sometimes the impression is all over the place, and the question was, is there pneumonia? And there's no mention whether or in some form or another. And then again, as I mentioned earlier, can someone who has the appropriate training but maybe has the very limited experience understand what I said? Because otherwise you're going to get phone calls, and those are disruptive. So I always try to say, is there anything in this report that's going to generate a phone call that I can avoid? One exercise you can try, and we tried this with our reports, and I've put different residents, fellows, attending reports, is take just the text and put it into like a chat GPT or something and say, can you make this more efficient? And see what it spits out. It's quite interesting. I did that with one of my reports. It was almost verbatim what I put in there. And then one variant, it said, it just described the abnormal findings and said everything else is normal.
That's a great exercise. I'll have to try that sometime.
Yeah, you could. Anyone can do that. They're all. There's a bunch of options out there, but you could try it and see what you get.
It's certainly a good way to challenge and see if you want to double down on your language for a specific reason, or if it really just can be simplified. From my end, probably the one thing that I would focus on, or that I try to focus on and have my trainees do, is to get connected with how your reports are going to impact management. And that's done through a few mechanisms. Probably the biggest one is through follow-up. So we have some automated follow-up tools where I will be reviewing a case with a trainee and say, we should follow this up and see what this shows at pathology. We have the right-click function where we'll get automatic results sent after pathology results are in. And I'll write a little note in the follow-up file that please forward it to me, just kind of getting them in the habit of following up cases and seeing, if something gets pathology or goes to the OR. I also think participation in tumor boards and a close relationship with colleagues and an open relationship where you're in frequent communication can really help you to understand the impact of your reports, what people care about, and how they direct management. Miranda, what about you? What are your tips or suggestions for improving reporting?
I love the sound of that follow-up tool. I wish we had something like that. I've got a very complicated process of reminders and future dated to-do lists that cover the same thing, but that sounds like a very powerful tool. My biggest sort of main teaching point around free text reporting, which is, as I said, the sort of mainstay of most radiology reporting in Australia, is the flow of ideas through the body of the report. And the teaching I have around that is moving from the relevant abnormal findings, so the things that are answering the clinical question that are a pathology, to the relevant normal findings, so those relevant negatives. There's a diverticulitis, but there's no perforation, so no free gas, no collection. And then moving to incidental abnormal findings, as a mass in the kidney that's solid and enhancing, and down to the incidental normal findings. So everything else is normal, or your little short checklist of this, and that is normal. That kind of progression is applicable grossly across the whole body of the report. It can be applied in anatomical subheadings. When you split it up into a neck, chest, abdo, pelvis, you're running that same algorithm across each of those subsections. And when you look at any kind of work of text that is trying to convey some kind of information, it's following that too. So we're talking about newspaper articles, we're talking about scientific papers. We're moving from the things that are key, the things that are the principal point of discussion, the relevant associated facts that go along with that, moving on to other facts which are incidental and not related but should be shared, and then tie up messages right at the bottom of the text. So that kind of principle, internalizing that and understanding that as you produce a piece of writing, is what gets out a clean message.
I think that's wonderful. Well said. And I just want to thank you both so much for this enlightening discussion. And of course, to our audience, we hope that you have found this useful and that you may be inspired to incorporate some of these elements that we have discussed into your radiology reports in the future. And with that, goodbye for now and happy reporting.
Thank you to Michael, Miranda, and Jeffrey for recording that awesome discussion for us at last year's conference. And before we get to your goatee response, Gaylard, I should point out that all three will be back for Radiopedia 2025 this July. Miranda and Michael are doing interactive case reporting sets. Michael's doing a GI tract diverticular disease lecture. Miranda is hosting the chest imaging workshop with Sally Ayesa. Jeffrey has recorded 2 new lectures and some case reads. Plus, there's a lung cancer screening panel with Miranda and Jeffrey. So if you want to hear and see more from them, then get yourself an all-access pass and come join the conference.
Yep, all three of them are excellent speakers and educators, and it's really thrilling that they're back for this year's conference.
Did you say
As far as
conference? Or
and I'm thrilled that they're back for this year's conference. Anyway, back to the podcast. As I listened, stop laughing. Anyway, as I listened, I was just taking some notes, and boy, oh boy, are there so many things that I could bang on about. But maybe I should let you go first while I gather my thoughts, Dixon.
Okay, all right. Just one thing from me, I wanted to agree with the pet goat that I think Jeffrey expressed. When you go through a case with a junior trainee, they have their own theory with the case. You tell them it's not the case, right? That's wrong, okay? And you specifically want them to report it like this. You give them everything, okay, lad? You give them the phrases, the emphasis, and then finally, when you get the preliminary report coming to you to sign off, not only have they missed most of your phrases and emphasis, but they've still snuck in their original wrong interpretation into the report. That gets my goat bleeding every time.
Oh, yes. Oh, there's a particular personality type that's prone to that as well. And I hate to admit it, but I reckon there's probably a reasonable chance that we were both like that. It makes it no less irritating, and I feel bad for my mentors. But
Nah, I'm a pleaser, Gaylord. I would have been a very good boy.
Good
back
boy.
then, at least. All right, have you gathered your thoughts? Let's have them, mate.
Yes. Okay, I'm going to limit myself to 3 things.
Mm-hmm.
Okay, firstly, but before I even start, I need to take a brief detour.
Here we go.
Did you know that the Hippocratic Oath, first do no harm thing, is not actually in the oath?
No.
I was Wikipedia surfing recently, and the oath itself does not contain that sentence or even anything really particularly close, although it has that general, don't harm people general vibe. The line probably comes from another book from the Hippocratic school. Apparently it's Epidemics Book 1, which includes what I think is actually a much better line, and one that we should sort of learn and lean into a bit. And the line is, practice 2 things in your dealings with disease. Either help or do not harm the patient.
Yeah.
And I think many radiology reports fail to live up to this. Not only don't they help the patient, because just describing findings isn't actually helping unless you answer the question or formulate an actionable opinion or, add something. But in fact, many of them actually do harm by describing irrelevant, accidental findings, hedging, suggesting unnecessarily follow-up or additional tests. And, we as doctors should, whenever possible, be putting our patients first. And that means not mentioning every single thing that you find, every perivascular space, every pineal cyst, every little thing. We're actually harming our patients when we're doing it. What do you think?
Yeah. Agree. Or would it be better for the podcast exchange if I passionately disagree?
Oh, yeah, we could have a beef about it.
Yeah. Oh, mate, the clinical questions are relevant to me. I just report everything I see. It's a stream of consciousness that I put out there on the page, and that's it.
Oh, there's so many reports that are a stream of consciousness.
They are, aren't they? Okay, what's your number 2, goat?
Okay, number 2. This is quick because I know we have discussed this exact topic before, but I think it's really important and relevant and is also a pet goat. And that is that the most important output we have as radiologists, our product, if you will, is our impression or conclusion or whatever it is that you call it at the bottom of your report. That is where we're contributing to patient management and where we're helping our clinical colleagues. And Jeffrey comments on this too. Too often, the conclusion that I see in external reports or some of my trainees or sometimes some of my colleagues is just a repetition of the findings, but doesn't actually move anything forward. Sometimes those are also the longest conclusions that have the least helpful things in them. And what's worse is that there are a whole bunch of AI tools that are coming out that one of the big perks that they offer is to create the conclusion for you based on the findings that you've reported. And so really radiologists then are relegated to the role of data entry monkeys, describing findings as they see them. And then the tool creates the conclusion for them. And, if you're worried about AI taking over our job, then using these tools is like telling the hangman you'll gladly tie the noose yourself.
The conclusion really is the juice, isn't it? So I remember during the live stream for this session that we just listened to, there was a bit of discussion in the chat box about whether people use conclusion or impression. And I had this strange experience, I remember it, at the time where I couldn't remember which I used. It was like I needed to have the dictaphone in my hand and to be saying a report in order to know what I actually say. I'm like, do I say conclusion or do I say impression? I can't. Anyway, turns out next time I was at work, I realized I don't say either of them. I say comment.
You should say, and the answer is stable.
All right, now, goat number 3, Gaylard, your final goat. Make it a good one.
Okay, number 3. This is more of an idea than a goat, really. But we used to report, and when I say we, it's probably even before my time, but we used to report on a piece of paper that went back to the one person who ordered the test. And it was personal. In some cases, it was someone that you knew as a referrer. And that in many ways, these reports were more like a response to a referral letter than a radiology report. I even remember some reports from older radiologists saying things like, thank you for referring Mr. Smith for his CT chest. As you know, he's had hemoptysis and this seems to be due to a mass at his hilum, which measures 4 centimeters, blah, blah, blah. Now, instead, reports go out to multiple destinations immediately. It gets stored in our hospital EMR to be read by interns and junior residents or by allied staff or nursing. It goes to the referrer, who might be a specialist, but it also goes to the primary care physician. And increasingly, it goes to the patient as well. And yet we're expected to issue this one report for all of these very different use cases. And here is where I think an AI tool could actually be pretty good. Maybe, and maybe it exists already, but maybe the report we can issue is just the highest level specialization report. So for example, if I'm dictating a glioblastoma, I'd report it for the neuro-oncologist and the neurosurgeon, and I'd use all the jargon and all the nuance that they find relevant. And then the AI tool could translate that into appropriate format for different readers, simplifying where it's needed, adding links to definitions or adding extra information as required, and even taking irrelevant detail out to make it more palatable for the intended audience.
Yeah, I think I've said this before on the podcast, but I occasionally use even the first person in my reports. Like I'll say, I suspect, especially when I'm, as Miranda put it, saying what I think, which is exactly what we should be doing in the conclusions of our reports. And in many ways, you have a specific implied reader in your mind when you say what you think. And that becomes a bit of a limitation to the report because you're talking to a specific level of understanding. Anyway, I feel like, if anything, we've clouded the awesome work of Hartung and his panelists with our discussion, Frank. So it might be the perfect time for us to wrap this episode up. How can people get in contact with us?
Well, you can email us at podcast@Radiopedia with any ideas or feedback. And you can join the Radiopedia community chat by visiting radiopedia.org/community.
Yes, you can email us just like Julian, a radiologist in the US Air Force, who writes, this is a short and sweet one, Gaylard. He says, if you guys start selling T-shirts, and then he has a little GIF, which is, what's his name, Fry from Futurama, and it says, shut up and take my money, and he's holding the cash out. So there you go. I like that one.
One day we will have some merch.
Do you think?
But no one will believe us when we actually...
That's right. It's like the boy who cried wolf. No, guys, we really have merch this time. We really do.
Maybe it's just a T-shirt with the word encephalopathy.
That could be good. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle income countries. Conference is fast approaching, July 21 to 25. Get yourself an all-access pass and get yourself registered. And what else can people do to help us out, Frank?
And you can also help us out by leaving a 5-star review in the podcast app of your choosing.
Absolutely. And we'll catch you all again sometime soon. Do you reckon once a month is too few an episode? What do you reckon, Galen?
I don't know. People have to tell us.
It's been a while since we did one. It
feels like a while.
Do you know what, though? I reckon if you say monthly, right, you kind of under-promise and over-deliver when you put in a little extra episode.
There's another school of thought, which is teach the audience to not expect a particular cadence.
That's right.
And just
that's right.
When it comes out, it comes out. It's when we have enough goats. We
should just put out 3 episodes in 3 days and then just leave it for 6 months.
Yeah, I'm sure that would work.
We'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Stay rad. And don't forget, the conference is coming.
Because
so there's going to be
hypoxic ischemic encephalopathy is usually ischemic.
Cut him off with his own encephalopathy. See ya. Bye, Frank.
Bye-bye.